Well, welcome to those of you who are here. We're going to give folks a couple more minutes to sign on, and then we'll go ahead and get started. We appreciate you being here for the webinar. We are all interested in making sure our journals get good manuscripts reviewed, and we appreciate you being here to help us do that. All right. Well, I think I'll go ahead and get started. It's 2 minutes after, so hopefully we have a quorum to get going. So today we're going to have a webinar on how to efficiently review a manuscript. And I hope this is helpful for you guys. What I would say, though, is if you want to read more about how to do this, the very best text I've ever seen on how to do this is this one, How to Read a Paper, The Basics of Evidence-Based Healthcare, written by Tricia Greenlaw and Paul Dykstra. This is in its 7th edition, and what I do as a fellowship director at my program is we take textbooks that are outside the realm of sports medicine and shoulder surgery and have my fellows read these. And we get together at 6 a.m. every other Wednesday and kind of go through these textbooks. And this is one that I would recommend that if you're a fellowship director, it might be something you want to have your fellows read with you because you can learn a lot from this book. It really taught me a lot. I do want to thank my panelists. We have Bill Mallon, who's the executive editor-in-chief of the family of journals. Ted Blaine and Michael Wider, they edit the currently seminars in arthroplasty. And Peter Chalmers is here representing reviews, reports, and techniques. And so they're going to be available. We'll kind of have them comment after I go through my short presentation. As you know, the American Shoulder and Elbow Surgeons started in 1982, and they started with the Journal of Shoulder and Elbow Surgery. And over the years, the founders have trained so many people who have then trained so many people and trained international people that the number of publications has grown and grown and grown and grown. And thanks to Bill Mallon, who was the editor of the Journal of Shoulder Elbow Surgery for 15 or 17 years, he found that he was rejecting a lot of really, really good papers because we just didn't have the space to publish them in JSES. So that led to JSES International, which is an open access journal, Seminars in Arthroplasty, JSES, and JSES Reviews, Reports, and Techniques. And I can tell you, I took over editing the Journal of Shoulder and Elbow Surgery from Bill in January. We're on track to get about 2,000 manuscripts submitted to us this year, and we can only publish about 15 to 18% of those. There just isn't enough space. And so we're actually filling these other journals with really good work, which is just awesome. And so, you know, when you review for one journal, you may actually be reviewing for the other journals because many of these manuscripts will get transferred with your reviews, which will help these things get published quicker than getting reviewed completely again. So just keep that in mind as you go through these manuscripts. Well, why should we review for the journal? Well, you know, when you're doing this, I think of yourself as being an arbitrator for the truth. The whole purpose of science is to help us understand what's going on and get closer and closer and closer to the truth. And when you see a manuscript that's reporting something, your job is to help us make sure that we are getting closer to the truth. I think a reviewer also helps their colleagues improve their work. If they submit a manuscript and they've forgotten important things that someone might want to know about, and you alert those authors to those, you're definitely helping your colleagues improve their work. If you are a scientist, reviewing manuscripts helps you think about your own science better. So this will improve your skills in science, and it helps you with your own research efforts. So reviewing is always a good thing to do. You get to stay on the cutting edge of science. The manuscripts are here. You get to see them before anybody's published them, anybody else has seen them. And of course, you get CME credits for doing this, which is also very helpful. And finally, to be a member of ASES, you are required to review for the journal. And I can tell you that if you're a candidate member and want to move up, or an associate member and want to become active, the membership committee seriously looks to see how engaged you've been in reviewing these manuscripts as a criterion for promotion in our society. And we're lucky in that regard, but it is something that's important. I kind of break it down like this. Your goals as a reviewer are twofold. Number one, you want to determine if there are fatal flaws, and we'll talk about these things a little bit. And if there's a fatally flawed manuscript, it really should not be published. You don't want to have garbage out there. And then the other thing is, if there's no fatal flaws, your goal really is just to help the author make their paper better. You're not there to critique them. You're not there to be haughty. You're not there to be obnoxious. Your job is to see what you can do to make this manuscript a better paper. So when we talk about evidence-based medicine, in general, there are 5 steps. We want to formulate answerable questions. We want to gather evidence. We appraise the evidence. We implement the evidence. Then we evaluate the process. And what reviewing journals is all about, and reviewing manuscripts is all about, is appraising the evidence. And we'll talk about that in a little bit. You do have to be critical. You have to know how to review a manuscript, which is why we're having this webinar. And you also want to weigh the validity of the work. You want to know, is this important? Is it valid? Is there bias? Are there things that impede the real science from coming out? And so you guys should all know this by now, but I can tell you when I was a resident and a young faculty member, evidence-based medicine had not hit orthopedics. And most of the articles in the journal were case series, and everybody would change their practice based on a case series. And then this came into play. It was in medicine first and found its way to orthopedics, this concept that different types of study designs have more validity than other types. And level 1 studies, of course, are the best, all the way down to expert opinion, which is level 5. And what evidence-based medicine asks us to do is to consider this when we look at the value of this manuscript. So I remember I went home to my wife, who's a scientist. I said, you'll never guess what's happening. They're doing this concept where we weigh the criteria of a manuscript, and if it's really highly regarded in level 1, we take that more seriously. And she just looked at me like I was stupid. But this really came to orthopedics late. But now, of course, you guys all get trained in it as you go through your thing. The concept here is we want to reduce bias. Bias is the poison of science. And when we look at these different levels of evidence, level 1 evidence is designed to try to reduce bias as much as possible. Level 5 evidence, which is expert opinion, is essentially nothing but bias. So bias is a danger. Reducing bias gets us closer to the truth. And that's really one way you can think about these hierarchy of evidence. When we review a manuscript, you can ask which section is most important. We have the introduction, the methods, the results, and the discussion. The introduction is supposed to tell us why we're doing the study. The methods tell us how we did the study. The results tell us what happened, and the discussion is so what. And when you look at all these different components of a manuscript, I hope you know this, but the most important section is the methods. The methods is what determines the validity of the work. And if you put garbage in, you're going to get garbage out. And if you have good methodology, the results that you find will be rock solid, and you can consider that closer to the truth. And this is where we find the fatal flaws in a manuscript is in the methods, and we'll go into more detail there. When we talk about science and talk about the different studies that you might be asked to review, there are different types of studies, and each type of study has an optimal way to do it. So there's different approaches for different types of studies. And the study design will determine the hierarchy of evidence and the level of evidence that comes out of this research study. Every study should have a hypothesis. When you look at a study, you should be looking at bias, and we'll talk about these things. I'm going to talk a little bit about statistical concepts, but there's really no math on this. It's just conceptual. And these are things that everybody should know, even if you're not a statistician. And then we'll go through a systematic approach to reviewing the literature, which you can use if you'd like, or you don't have to, but we'll talk about that. So when we talk about different types of studies, there's therapy research, diagnosis research, screening research, prognosis research, risk factor research, and economic analyses. And this is how we can categorize research in a general sense. There's other things as well, but this is most of what we see. And each of these type of studies has the best way to do it, and that makes it high-level evidence. So you'll see these tables in journals. We have one like this in the Journal of Shoulder and Elbow Surgery. Every journal has something like this in their instructions of authors. But what it does is it breaks down the level of evidence for a particular type of study and the optimal way to do that study. And we'll go through these in a little bit more detail. This is something that's been around and it continues to grow and develop, but there is recommended formatting when you review a manuscript. So if you look at a randomized trial, the consort statement is a way to make sure the authors have included everything that should be included in their manuscript. Observational studies use the Strobe checklist. Systematic reviews use the Prisma. There's actually one of these for every single type of manuscript you can think of. Even now, machine learning studies have checklists and recommended formatting. And so when I'm reviewing a journal, this is one of the journal article. These are one of the things I look for. Did they use these kind of things to help them construct their manuscript and make sure all the important elements are inside that manuscript? And this is all on the Equator Network. If you do equatornetwork.org and explore their website, you can see what all these things are. And if you're doing studies, you should consider getting this down and downloading the checklist so that you make sure your manuscript is formatted appropriately. But this is something I always look for when I review a manuscript. Now, therapy research is really designed to test treatments. And in our world, it might be different surgical treatments, it might be different drug treatments or interscaling block methods or other interventions. And for an example, there's a lot of debate in our world about if someone has osteoarthritis and an intact rotator cuff, which arthroplasty is better? Is an anatomic better or is a reverse better? And if you go to any shoulder meeting, people debate this on and on and on and on. And it's okay to debate it, but if you want to study this, you would want to do a randomized controlled trial. That's the best methodology to test a treatment, a therapy research, as a randomized controlled trial. Diagnosis research demonstrates the validity and reliability of diagnostic tests. For example, let's say you develop a test that's supposed to pick up SLAP lesions on physical exam. The best way to do this is with a cross-sectional design study, and we'll talk about this a little bit. It's funny, if you've ever read Steve O'Brien's test, and everybody likes to use this in clinic, his manuscript is exceedingly poorly done. It is ridiculously poor. But it's popular, so everybody does this test. But what's interesting is he had really high sensitivity and specificity levels in his hands, but no one else has been able to match those. Again, it's because the way he constructed it, garbage in, garbage out, and when somebody tries to reproduce it, they can't get the same results. So there's optimal ways to do these kind of tests, and for diagnosis research, a cross-sectional design is the best. For screening research, this determines the value of a screening test to try to test a disease at an early stage. For example, the PSA test looking for prostate cancer. The method here, again, is a cross-sectional survey. And prognosis research determines what's likely to happen to someone when a disease is picked up at an early stage. This looks at natural history of disease. For example, do small rotator cuff tears become large? Who is that going to happen to? And the best way to do this kind of research is to find people in the beginning of a cohort and follow them over time to see what happens in the natural history of the disease. That's a prospective longitudinal cohort design. Risk factor research determines if an exposure to an agent or a risk predisposes to the development of the disease. When I was young, everybody talked about acromioplasties and the hooked acromion associated with rotator cuff disease. That whole concept was based on one abstract in cadavers where they looked at rotator cuff tears and they found that people with cuff tears were more likely to have hooked acromions. There was an association there. We then went and made a causation. We then assumed that the hooked acromion caused the cuff tear, but it's quite possible the cuff tear changed the kinematics of the shoulder, which then produced the hooked acromion. In a retrospective or cross-sectional design, you can't answer that question. You can show associations, but not cause and effect. The best way to do this is to do a prospective cohort, get all these people without cuff tears, look at their acromions, follow them over time, and see if there's a relationship that develops. So again, we talked about the different types of research. Each one has its optimal study design. These are the study designs that we kind of mentioned: randomized controlled trials, cross-sectional surveys, longitudinal cohort studies, case control studies, and case reports and case series. Now, one of the things you want to look for when you're reviewing a manuscript is this truly a prospective study or a retrospective study? Retrospective studies, the highest level of evidence they can be is level 3 because they introduce bias. If it's prospective, it could be level 2 or even level 1 if it's done well. And the real answer to that question is, when was the research question developed? You'll see people say this is a prospective cohort, but their IRB was submitted after all the data was collected. And that's a trick. To me, that tells me that they asked the research question after the data was collected in a prospective cohort. And that makes it retrospective. And the reason is, if you ask the research question after you've collected the data, you don't know if you've collected the right data to answer that question. But if you ask the question first and then start collecting data the best way you can to answer that question, that is way more powerful and reduces bias. So be careful when somebody talks about their study being, a retrospective study of prospectively collected data. Sometimes they don't mention it. I always look at the IRB if I can't tell, because if they've submitted the IRB after the data collection, that means they asked the research question after the data collection. So be careful with that. Randomized controlled trials, of course, are considered the gold standard, but really they're the only gold standard for treatment research. If you're trying to look at prognosis research or other things, a prospective cohort is actually the gold standard. So even though everybody loves randomized trials, the randomized design is not best for certain research questions like natural history studies. But here again, it's prospective. The research question is asked way before you collect any data. Randomization is designed to eliminate bias. If you randomize people, your two populations should be exactly the same. And that assures comparative groups and prevents weird things from influencing your outcomes. And that's where the controls come in. And these are, if they're done well, these are the best research designs we have for treatment studies. The longitudinal cohort study is also a prospective design. Essentially, you take a population without the disease and follow them over time to document risks and the development of the disease. And here you can identify the exposure to the risk before it happens, before the disease happens. These are natural history studies. So again, here we're thinking about now people with flat acromions may be more inclined to have B2 glenoids. Well, most of this research is retrospective cross-sectional cohort studies. It's all level 3 evidence. To really know this is to know if this is true, you should get a big population of people with acromions and then follow them over time and see if people with flat acromions develop the B2 glenoid. And then you eliminate bias. A cross-sectional survey is when data is collected at a single point in time for a population of interest. It could be when people present to the clinic with shoulder pain or a big population of runners, for example. You can compare those with the condition to those without the condition. And of course, it requires a gold standard to identify the condition that should be applied to everybody in the population. We see a lot of this, the retrospective cohort comparison using large database. This research is relatively easy to do, and we get tons and tons and tons of manuscripts with this. We hit the pearl diver with this research question and found people with this disease and people that didn't have this disease and compared them. By their very nature, these are all retrospective design. As a result, their level of evidence can only be level 3. It cannot be higher because the data was collected before the research question was asked. It compares two cohorts. People can look at the effect of treatments. They can look at prognosis. These are large database analyses. These studies are at very high risk for selection bias and other forms of bias, which is why the level of evidence of these is not high. They can only demonstrate associations. One of the things we see with these is people will find something that correlates, and then they'll make an assumption about causality. Well, you can't. These only demonstrate associations, not cause and effect. And so we'll talk about spin in a little bit, but one of the things you watch for in the discussion is how they interpret manuscript data if it's retrospective, because they really have to be careful about what they say. A case control study, this is sometimes what we see in these database mining studies. We also see this in people that look at their populations, but it's subjects with a condition are matched as closely as possible to a control group without the condition, and then they look at past exposure or look at things that might influence the development of the disease that makes these two populations different. Again, this is cross-sectional. It's not prospective. Associations are detected, but not causation. To demonstrate causation requires a higher level of evidence, which usually requires a longitudinal cohort study to show an effect. And then, of course, when I was young, this is what the literature was full of: case reports and case series. Here's a collection of cases. This is how I did my thing. And there's no controls. There's no design. It's helpful in identifying condition, but really, I'd be really careful about using case series to change my practice, because without a control group, you're really not sure what's going on. And then, of course, we have expert opinion. We have narrative reviews. We have consensus statements, the Delphi process, the AUCs that the Academy puts out. These are all opinion-based. They may be right. They may be wrong. There was a long time when everybody thought ulcers were caused by acid. Now we know it's a bacteria. It was all expert opinion. Millions of dollars literally were spent looking at the effect of acid, developing antacids for ulcers, and it turns out it's a bacteria. So be really careful with expert opinion. If there's no data available, then yes, you can use it, but just tread lightly into this space. And you will see in JSES, it would be a really exceptional narrative review for us to publish it. RRT will see a lot of these, and if they're very good, they'll publish it. But if there's data that's good data, that would be a better thing to rely on. So some other things to consider: there are multiple sources of bias in clinical research. It can occur anywhere along the line with trial planning, trial implementation, data analysis, and publication. And so you don't have to know all these. I have an article that lists at least 25 different sources of bias and types of bias we can find. The one thing that you have to be careful about as a reviewer is something called confirmation bias. We all have beliefs. I used to believe that every rotator cuff tear needed to be fixed. When we see evidence, we tend to believe the evidence that supports our own beliefs. We tend to ignore the evidence that flies in the face of our own beliefs. That's confirmation bias. And when you're reviewing an article, you really have to check that at the door and keep an open mind that the data that you're reading may not actually fall in line with what you were taught or what you're thinking, but it still may be true. So approach things with an open mind, recognize that we all have confirmation bias, and try to put that aside when we're reviewing papers. So one of the things Bill likes to point out in the instructions for authors is they really want to have the hypothesis, the last sentence of the introduction. This is the essential question driving the research. You should have a hypothesis. You shouldn't say, we hit the database to see what we would find. That's a fishing expedition. Typically, a hypothesis is formulated in a specific way that allows specific statistics to be applied to it. And it's very specific. In the perfect world, it will answer one question. This hypothesis then determines the type of study that you're doing, which then determines the methodology. And again, you should look for it specifically in the introduction part of the manuscript. And again, bias, as I mentioned, is the poison of science. I'm going to talk briefly about some of these, but there's multiple forms of bias. The most common ones we see are selection bias, performance bias, exclusion bias, detection bias, and confirmation bias, as I already mentioned. Selection bias occurs when the populations that are compared are not the same. For example, if you go hit the NISQIP database and look at two different populations, but one population is 10 years older than the other, they're not the same. And that difference in age may be influencing the outcomes that they're detecting. That's selection bias. You're comparing apples to oranges. And you don't know if the effect of the treatment was due to the treatment or differences in the population. This is why prospective and randomization design tries to eliminate selection bias. There are good methods to randomize and there's bad methods. So when you're looking at this, you want the authors to specifically state how they randomize their patients. If they used a random number generator with envelopes that they opened up at the time of the intervention, that's a good method. That's clean. If they use methods like date of presentation to the clinic or surgeon to randomize patients, that's not so clean because those can be influenced. My nurse might say, hey, Dr. Kuhn does his surgeries. He's randomizing people to therapy and surgery by date of clinic. If you want surgery, go see him on Tuesday. That can be manipulated. So those are bad methods of randomization. If they're bad, it can produce selection bias. Performance bias occurs when there's a difference in care provided from other sources than the treatment. For example, if you have multiple surgical treatments, you don't know what produced the outcome. There are a number of randomized trials in the literature that looked at non-operative treatment versus surgical treatment for rotator cuff tears. And in general, if you look at that data, surgical treatment comes out statistically better, not much on the MCID of the PROMs, maybe not so clinically significant, but statistically better for surgery. But what also happens in these studies is about a third of the patients who have surgery have worked on their biceps. This is performance bias. I don't know if that extra bump that the operative patients got was from fixing their cuff or taking care of their biceps. The people in the non-op group couldn't have their biceps addressed. That maybe is why they did worse. I don't know. That's performance bias. So that's one of the things you have to watch for. If the interventions are documented and controlled, then you'll be safe. But if there's a difference in the two populations, that's a concern. Exclusion or transfer bias occurs when there's a difference in follow-up. We like to see more than 80% follow-up in the cohorts in our studies to know that the effect of the intervention is real. If you have a less than 80% follow-up, we have no idea what's going on with those patients. Now, in a good study, if they have less than 80% follow-up, they can do sensitivity studies and say, well, let's say everybody that was lost to follow this pathway and see what the stats show. Or let's say everybody who was lost to follow-up went this way and see what the stats show. And if your population is big enough, you may be able to argue that you're doing okay. But this is important. All groups should have similar follow-up. We talked about confirmation bias, and as a reviewer, I think it's important for us to recognize we have that and try to check that at the door. But you will see this in papers, and it leads to something that's called spin. Spin is when someone exaggerates the clinical importance of their findings. They identify correlations as strong when they are not. They will state differences exist when they're not statistically significant. They will promote statistical significance for differences that are not clinically meaningful. These are all things we see all the time. We'll see somebody that said, we did a correlation and look, our p-value is 0.0001, but the correlation R was weak. Well, that's not a strong finding. It may be statistically different, but it's clinically not that meaningful. And you'll see this a lot. And trends is another thing you'll sometimes see. We did not reach statistical significance, but there seemed to be a difference between the two groups. That's not good either. That's not real. So be careful when you read these manuscripts about spin. The authors think they have something here. They spin their data if it's not very strong. I'm going to spend a few minutes talking about statistics. You don't need to be a statistician to review a paper. You do need to know some fundamental concepts that I'm going to talk about p-values and power, what statistical significance means. We'll talk a little bit about types of data and a little bit about statistical tests, and then talk about clinical significance. There's really no math here. If you get these concepts, you can look at the statistics the authors used and make some comments on that. But if you're never concerned, just put in your comments, this would be good to have a statistician look at it. We have a few statisticians that we send papers to review to be sure the statistics are good. So if you have a concern, just make that known. When you're doing a research study and you have a hypothesis, you can think of it like a trial in a courtroom. There's an individual who's been accused of something. That's your research hypothesis. I think this drug is going to work. In the United States, that person is innocent until proven guilty. And this sounds crazy, but that's how science works. You actually take the opposite and say, I think this drug works, but the null hypothesis is it doesn't work. And that's what the whole study is based on, is the null hypothesis. Then you collect evidence to test that. And you want to convince the jury, which is essentially your p-value, but we'll talk about that. But you want to collect evidence to test the hypothesis. Evidence is the power of the experiment. If you have enough evidence, you can actually make a determination if that guy is guilty or if he's not. If you don't have enough evidence, well, you'll have a hung jury. So you can think about the power of the experiment like evidence. What probabilities are statements about how likely the effect you found is due to chance. P-values are not magical. We tend to use P of 0.05 as a convention. And in a criminal case, you need to find the guy guilty beyond a reasonable doubt. And maybe a P of 0.05 is 5%. Maybe that's beyond a reasonable doubt. What's interesting in the court, if in a civil case, you just need a preponderance of evidence. That might be a p-value of 0.1 or 0.5. So p-values are not magical, and we're going to talk about that in a little bit. When you have a trial, there's 4 outcomes. You can have an innocent man found innocent. Well, the null hypothesis was he was innocent, and you went through the trial, and you found, in fact, that he was innocent. That's the correct outcome of a trial. Another outcome is when a guilty man is found guilty. This is when you reject the false null hypothesis. The null hypothesis was that he's innocent. Look, we got all this data. He's guilty. You reject the false null hypothesis. The guilty man is found guilty. That's a correct outcome. 2 other outcomes are possible. You can have an innocent man who was found guilty. We don't want that to happen. That's when you reject the true null hypothesis. The probability of making that error is what the p-value is. So that's saying, look, there's an effect here. The probability is 5% that I've made a mistake. That's what the p-value is. The final outcome of a trial is that a guilty man can be found innocent. This is when you accept the false null hypothesis. Again, the null hypothesis that he's innocent, the false null hypothesis that he's guilty, here you find a guilty man is found innocent. This usually occurs when you don't have enough evidence. And that's the power of the experiment, when you don't have enough evidence. So the p-value really is just the probability of finding an effect when one does not exist. What's the likelihood that I made a mistake when I find a difference between these 2 populations? It's rejecting the true null hypothesis. It's the probability of convicting an innocent man and the probability of making a mistake. That's all it is. And because all of science is sampling, we never know the truth. We can only get close to the truth by probabilities, and that's what the p-value is. If the difference between 2 groups is not statistically significant, then the groups are not different. That's an important feature. You'll see people say, oh, look, the difference here was 20 points on the row scale, but the p-value was 0.06 or 0.6, and that was a trend. Well, no, you can't say it's a trend. They're not the same. They're not different. You can't say they're different. Using the word trend is misleading. The data samples are either statistically significantly different or they're not. And if they're not different, you can't squeeze a relationship out of it by saying the word trend. That's spin. And again, that's because the authors have this confirmation bias. So that's something to watch for when you're reviewing a manuscript. One of the things that's my personal pet peeve is multiple p-values. This is all about sampling. When you do a sample of a population, you're trying to sample the population at large, right? When you see a study, you've got a population sample. Well, if you take that sample and you do test after test after test after test on that sample, you're going to start getting tests that just pop up randomly by chance that are not real. You're going to get p-values that are not real, false positive p-values. And this will require a correction for multiple comparisons. This is a graph that shows the probability of at least one p-value is less than 0.05, and the independent number of decisions is on the bottom. So the more questions you ask, the more likely you're going to get p-values that are significant that aren't real, that are just due to chance. And you can see, you got a 50-50 chance with 15 questions, 15 p-values. This is a chart from a paper that was published. This is table 3. There were like 6 other tables, and they all look like this. This one table has 84 p-values. Many of these are not real, and that's why you have to do a correction to get closer to what really is important, what really is the truth. And so this is an important concept that I always look for, and I hammer people when they have to do corrections if they get multiple tests looking at one data set. This is a fishing expedition. This is let's go to the big database and see what pops up. And look, oh, this is significant. This is significant. This is important. Not if you do a correction, it may not be. So we talked about the power of the experiment. That's essentially evidence. And the power of the experiment tells you if you have enough data to find an effect if one exists. If you have small sample sizes, you may not have enough power to show a difference between two groups. This is when you accept a false null hypothesis. It would be like letting a guilty man go free. You just don't have enough evidence to show the effect. When someone says there is no significant difference, it does not mean the two populations are the same. That's a subtle but important point. You're sampling. If you have two populations and you do the analysis and you don't have a statistically significant difference, you can't say they're the same. You can say they're not different, but you can't say they're the same. To test equality requires a lot more statistical power. And so that's something you have to be careful about. If somebody does a study, it's underpowered. They said this group is the same as this group, so you could treat them the same. They're not the same. They're just not different. And I know that sounds confusing, but it's an important point to make. So when we talk about statistical significance, we can ask, what's so special about 0.05? Nothing. It's a 1 in 20 or 5% chance of stating an effect when none exists. It's a convention. It's arbitrary. If you have a really toxic drug, you might want the p-value to be really, really strong so that here's a probability that I made a mistake that this drug works. For other effects like biomechanical study, you may be okay with a 0.1 p-value. That's a 10% chance of making a mistake. If it's not that clinically meaningful, you may be okay with that. So don't focus in on the 0.05, but think about what kind of probability you're willing to accept when you talk about this. Another point that's really important is that statistical significance and clinical significance are not the same. So you will see studies that report p-value, 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 and they may be 0.00007, but the difference between the two groups is small. So this is why we have features like the MCID and patient-reported outcome measures, days in the hospital, active range of motion. I got a statistically significant difference between 140 degrees of forward elevation and 145 degrees of forward elevation, and in weak correlations. These are all things to watch for. If it's statistically significant, you have to ask, is the difference they detect clinically significant? Now, we're going to talk a little bit about statistics here, and I'll make this quick and brief because there's not a lot there. I don't want you to memorize this, but basically there are two types of data. There's discrete data, which is categorical data. This is when data falls in discrete groups like excellent, good, fair, and poor. And then there's continuous data that falls along a curve. like times in a race, height, weight. The type of data determines the statistical test the author should use. So for tests of discrete data, they have tests that are focused on frequencies, like chi-squared tests. For continuous data, you're looking at statistical tests that have variation from the mean. That's the student's t-test. And so you've all seen these words, chi-squared, student's t. Really, all you have to remember is chi-squared is for discrete data, looking at frequency. Student's t is for continuous data. If you know that much about statistics, you're ahead of most of the people who know. Now, when you look at continuous data, these are some examples on the curves. There's a bell-shaped curve. If it's parametric, that means they're equal about the mean. It could be non-parametric or skewed data. And again, the concept is a parametric statistical test uses recognizable tests. So students t-test. I've heard of that many times. The non-parametric statistical tests are a little bit less common. And so those are going to have weird names like Kruskal-Wallis. So that's all you need to know. If you know that, you can review the paper. And if you don't know that or need more information, just write down, I think this needs statistical consultation, and the editors will take care of that for you. So again, we talked about the difference between statistical significance and clinical significance. You have to look closely at the difference that was detected. Here's an example from a paper. The hospital stay in one group was 5.5 days, and the other group it was 5.9 days. It was highly statistically significant. Well, is 0.4 day important? Is it clinically important? I don't know. You know, Mellon hates when people put measurements out to like 16 decimals. It's meaningless. When you use a goniometer, what is the error in a goniometer? It might be 5 degrees when somebody's using a goniometer. So if they detect a difference that's 2 degrees, I don't care how significant it is, it may not be important clinically. So these are things you kind of have to think about as you're going through the paper. And again, spin is related to confirmation bias. It's overinterpretation of the results. The most common thing that I see is when someone has a level 3 cohort study and they infer causation from correlation. Someone said, carve the most scary thing you can think of on this pumpkin, and that's inferring causation from correlation. This is what a statistician would have on his front porch on Halloween. So how do you approach a manuscript? Well, we're going to redo this, but Kurt Spindler, Warren Dunn, and I put this together 20 years ago, and it's in the Yellow Journal, and it's a way to kind of approach a manuscript. And basically in that, we have these appendices that help you do this. And if you've never done reviews of a manuscript before, this can help guide you through reviewing a manuscript. And I'll go through it kind of quickly here. So the first thing you want to do is look at your manuscript and record the title, authors, and citations. So this is a study from 2010, non-operative management of adhesive capsulitis of the shoulder, oral cortisone application versus intra-articular cortisone injections. Well, this is interesting. All right. Identify, record the hypotheses. There's usually a primary hypothesis. There may be a secondary hypothesis. Here's the abstract from that paper. We hypothesize that oral application of cortisone oral application of cortisone leads to comparable results and avoids the risk of joint infection. Already my ears are peaked because that's not really a good hypothesis to show that things are the same. That's an equivalency trial. This is not what these guys are doing. So I'm already concerned about that. The study compared intra-articular injections of cortisone with oral glucocorticoid application in the treatment of adhesive capsulitis. Our hypothesis was that both applications of cortisone would lead to improvement. It sounds to me like they wrote this hypothesis after they got their data. That, normally you would do a study to show that one is better than the other. So I'm already suspect. But anyway, I put down their hypothesis. All right, then we say, what type of study is this? This is a treatment study. What is the study design? It should be a randomized trial. And in these handouts that we had in this manuscript, it had the different types of studies on the left and then the best research design on the right. And then you can say, okay, what would be the level of evidence for these things? And again, we can look at this and determine the hierarchy of evidence. Here's their methods. It said in a prospective randomized evaluation, 40 patients with adhesive capsulitis were treated with oral steroids or 3 intra-articular injections, and they followed these patients with these things. So this is a treatment study, and they said it was a randomized prospective trial. If you dig into the methods a little bit deeper, they had 45 patients, some of which were excluded. Their breakdown was 20-20. They really don't tell us how they randomized this. They did some physical therapy with these people, and then, a post hoc power analysis. Well, that's not good. You should do a power analysis before you start collecting data so you know what your N should be. I already know in this study they did not find a difference because our hypothesis said they were trying not to find a difference. And I already know it's underpowered. I can stop right here. This is not a level one study because the methods are here. And this is, again, the most important part of the manuscript. This is where you find fatal flaws in a manuscript. So they had IRB approval, which is great. This is their methods. Then you want to look at their follow-up, and one of the things you can do is see who left, and how many patients stayed in the follow-up. Make sure they have a lot. Make sure the people that did the examinations were not aware of the treatment that was rendered. That's called blinding by some people. And did they use validated outcome measures? So these are all things we look for that can try to reduce the risk of bias. And what I like to do is I create this table and run through it. And so you can start with the number they started with, how many got the intervention, how many had initial follow-up, how many had final follow-up, what the percentages of follow-up were, and what the outcomes were. And then you can look at their data in a very general way statistically. You can just sit back and think, is this data discrete or continuous? Well, if they're using a visual analog scale for pain, that would be continuous data. And if it's continuous, was it parametric or non-parametric? And then what tests were used? And again, chi-squared for discrete, common test like student's T for parametric, weird name test for non-parametric. If you know that, you're way ahead of the game. Then you look for multiple p-values to make sure this wasn't a fishing expedition. And you ask for a correction if they have multiple comparisons. So here they did their stats. Non-parametric variables were used, paired t-tests, and independent t-tests. They might have needed to use something different. They said their variables were non-parametric. I might have a statistician look at this one. And then you can go through this checklist to see if this is done. And if you're worried about it, just have a statistician look at it. And again, this is a table we had in that manuscript. I'm hoping in the next couple of years to rewrite that manuscript and include more things. But this gives you an idea about what the data should look like and the best test if it's parametric and the best test if it's not parametric. Okay, so now you look at the data and now you look at their findings and the results and you ask, are the results statistically significant? If the answer is no, you want to know, do they have enough power to detect a difference? Here in this study, they talked about doing a post hoc power analysis. That tells me they didn't do it beforehand. There's a very high risk that they don't have adequate power. If the differences are statistically significant, now you sit back and say, okay, but are they clinically important? And so that's what you would look at. So here they did a post hoc power analysis based on external rotation means. Well, I thought their study was designed to look at pain. Huh. This is bad. This is not, if I were the, no offense, Bill, I don't think you were the editor here in 2010, but I would have rejected this one. This is just bad. This is fatal flaws. Nevertheless, you can put it into this table. You can put the outcome measured, the absolute differences between the two groups. Is it statistically significant? What's the p-value? If it's not, whether it's adequately powered, is the difference is statistically significant? Is it clinically relevant? So here is the data from this thing. They looked at pain. Here's the difference in the two groups. The absolute difference on the pain score was 0.3. It was not statistically significant. The p-value is 739. It doesn't matter if it's powered. It's not statistically significant. And it's not clinically relevant because a difference of 0.3 on the pain scale is not important. Function difference, 1.7. Again, not statistically significant. Interestingly, patient satisfaction was statistically significant different. The people that got group one were better than people with two. I would be willing to bet the people that got the shot were probably did better because of the placebo effect. But this is not great data. So the best this can be is level 2. It's a randomized trial, but it's really poorly done. And it's one that I would have a hard time accepting, frankly. So here's a poor quality randomized trial, level 2. You can use this table to help level it. So again, your goal as a reviewer is to determine if there are fatal flaws. And you have to know a little bit about methodology to be able to do that. And then help the author make his paper better. If there's things they've forgotten, things that need to be included, papers that they didn't include, if they spun the paper, spun their outcome, you have to kind of hone it in and make it a little bit better. Don't be judgmental. Leave your own biases at home. And what specific things do you think would make this paper better? Every author wants to produce good work. You're not there to criticize, you're there to make their paper better. And if there are fatal flaws, we need to know about that. So AI is something that's a hot topic right now. We've done some experiments with AI reviewing papers. It's pretty amazing what it can do, and I think in the future AI will be used to help us review papers. But as of today, you're not supposed to use AI to review papers, so don't do it because we know when you do it. All right, so then on the editorial management website, you're asked to enter information. The point that's important for you is the comments to the author. This is where you want to put in comments to the author. We don't want you to put in whether you think it needs to be rejected or transferred or what to do with it. Just lay the comments in. If you want to say, I think this should be rejected, put it under confidential comments to the editor. Because anything you put in for the author, unless I edit it and don't send it to the author, they're going to see it. And you don't want to put something like, I think this is a piece of crap. Oh, da 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 da. You can put that in the confidential comments to me and the other editors. But for the purposes of making their manuscript better, you want to put comments to the authors that will go right to the author. The production notes, you really shouldn't put anything in here. This is for the production people, the people at Elsevier. This is like this letter to the editor should be matched with this manuscript when the print edition comes out. You really shouldn't have to put anything in the production notes. Your space should all be up in the comments to the author and then confidential comments to the editor. One thing to think about when you're reviewing papers is the impact. JSES has very limited ability to put papers in print. We transfer a lot of good papers, and we try to get the ones with the highest impact in JSES. So we ask you to rate this paper. Is it in the top 25%, top 50%, top, bottom 50%, bottom 25%? If you think this has high impact, put that in the confidential comments to the editor. Say, this is really important. I would use this to change my practice. Let us know what you think, because that can be really helpful. So that's essentially the talk. I'm going to open it up to my panelists and see if you guys have any questions. Again, Elsevier has a lot of resources about how to review papers, so you can go on their website. This is an article that was in the Journal of Electrocardiology that was pretty good. You can download our paper it's a little dated now, but it was from 20 years ago. But I would strongly recommend you get a hold of this book, How to Review a Paper. It's an easy read. It will make you a better reviewer by far. Again, my fellows, we're going to start in August with my fellows and break it down over the next 2 or 3 months. We're going to read this book with them, and they will be really good at reviewing papers when we're done. So in summary, I think it's helpful to understand the hierarchy of evidence and know why it exists, know the types of research and the types of studies, look for bias, understand what p-values, power, and clinical significance are, recognize types of data and have a general understanding about the stats. And remember, your goal is to determine if the paper has fatal flaws, and if not, help the author make their paper better. Thanks for listening. So I think at this point, I'm going to stop sharing my screen and we will open it up to the panelists and see if anybody has any questions. And feel free to chime in, Bill and Michael, Ted, and Peter, if you have things that you've seen
yeah, I'll start. Excellent talk, Jed. I mean, I learned a lot just listening to your talk. A lot of great information in there, so thank you. I'm sure we've got a lot of young reviewers on the call. I just tell you, when you're starting out doing these reviews, they are going to take you a little while. It's one of these things that you will become more efficient at as you get more under your belt. And so the first couple, you're going to feel like, my God, this is so time consuming. It is, but it's a learning process. And I'll tell you, after you review a paper and put some thought into it, you're going to really learn a lot about that topic. And as you do more of these, it's going to make you a better, not only a reviewer, but if you do research of your own, you're going to become a better researcher and make better designed studies. But in the end, you're going to become a better clinician and provide better care to your patients. You're going to be able to review the literature quickly and efficiently and be able to pick out good studies from bad. And there's a lot of studies published that aren't very good science, like the one that Jed presented. So it's a great learning tool for you, and it provides a wonderful service for the ASES members and then for the public at large and our patients. So thank you for doing it. One thing I would say, kind of on a housekeeping thing, is that if you have a study that you quickly determine has a major fatal flaw or a couple of fatal flaws that would prevent it from being publishable, you don't have to get too deep into the weeds into your review and come up with a lot of line by line edits. So if you find some major issues with the paper that there's no way it could ever be revised and published, you can put a pretty short, succinct review, but clearly spell out why you think it's unpublishable. And don't put a lot of time into, like I said, picking it apart, line by line.
So I'm just going to interrupt for a sec. Keith Kentner is on, and he said, "Do we have a policy allowing fellows to review manuscripts, and what do you recommend?" Well, that's a great question, Keith. When I look for reviewers, I purposely go into things like PubMed and other search things and try to find reviewers that have had some experience or expertise in the topic. I hate to brag, but my son did a lot of concussion research as an undergrad and published a ton. And in medical school, he published a ton, and he was reviewing for the journal Concussion because he'd published so much on it as a medical student. So I don't have a problem with fellows reviewing at all. In fact, I think it's a good experience for them, particularly if they have expertise in that topic. If they don't have expertise in that topic, I think it's still okay to teach your fellows how to review, but as a fellowship director, you should then look at their review and go over it with them and teach them how to do it better. So the answer is yes, let your fellows review. It's a good exercise for them. But if they're not an expert in that topic yet, their attending should oversee that review with them. And Keith, I would strongly suggest that you get this book for your fellows and break it up into sections and review it with them. It will make them better reviewers for sure. Other comments or questions?
Yeah, I'll just make a comment. First of all, fantastic talk, Jed. I mean, I think if we all, have access to this talk and then read the paper that Jed wrote, I mean, everything is in there that you need to know about a review. So that was fantastic. I also wanted to just echo Michael's comments and say thank you to all of the folks who are on here today and all those who review, because it's not compensated work. I mean, it's a duty and a responsibility, but we really do appreciate that. I did want to comment, a little bit on just the workflow, what's happening on our end and what our expectations are. The target workflow to get a paper in and out is about 45 days. And that requires multiple steps. It has to go through an editorial check, then it has to go out to the editor-in-chief, and then to the associate editor, and then out to reviewers. So we're really looking for, about a 10 to 14 day turnaround on our peer reviewers. So, just practically, probably the best way to do that, thinking that it takes you about 2 to 3 hours to do each review. That's what most people say. Maybe when you get to be good at reviews, maybe that's what it is. Maybe it's more in the beginning, but probably scheduling something like 1 day a week for a couple of hours a week to put that into your schedule for this responsibility for reviewing, I think is a good way to do it. So again, just some comments on what the workflow expectations are from our side.
Peter, why don't you tell us how you got started reviewing?
Well, first off, that was an amazing talk. I mean, I wish you could come and give that talk to my residents, and just so that, because it's such a great encapsulation, not just of research, clinical research in general, but the pearls and pitfalls. And I completely agree with the comments that have made that it is important to get, if you get a request to review, try and turn it around quickly out of respect to the authors, who've put a lot of work in and don't want to wait 4 months to learn the outcome. And I completely agree with Mike Weider. It can be really overwhelming, but often you can, with the guidelines you provided, you could spend 10 minutes and weed out, this is a great paper, this is a not great paper. And then it's the ones in the middle that I think really need our help. And that's kind of the rubric I've started to use, is I try very hard, and when I started reviewing, to try and dive in and determine what advice can you provide to the authors that will improve their paper, even if that advice is along the way of saying this manuscript is not appropriate for the Journal of Shoulder and Elbow Surgery. But I agree with everything you said, that reviewing is the best way to improve your own research, but it's also a way for you to have a better understanding for what our literature is, and that makes you a better doctor. So that's it's mutually beneficial, even though it can seem often like the last thing you have time for.
Thanks. Do we have any other questions? And I'll let Bill Mallon comment. He hasn't spoken up yet.
Can I say one more thing?
Of course. Yeah.
I think we one of the challenges that I think we really have in today's academic environment is a lot of people are kind of numbers driven. Like, well, I'm sure that academic people on this call have the same thing where like once a year I get a request like from my chairman that it's like, how many papers did you produce and like how many talks did you give? And one of the challenges with reviewing a manuscript is it doesn't necessarily show up anywhere on your CV, but it is like infinite good karma. It will help you to be more productive in the other avenues that you do. So it's sometimes a challenging thing to prioritize, but I think should be at the top of everyone's list.
You bring up a really good point. At JSES, we actually have our top reviewers, and at the annual meeting, they get a special ribbon. That may be something we need to like quantify or put something down that says, send a message to your chair or your boss that says you were a top reviewer for JSES. We might want to do that, Steve. Can we set that up?
Yeah, let's discuss it offline and figure out what exactly that would look like.
Yeah, we recognize the top reviewers. It might be nice just to send their boss a message that says, "Hey, this is one of our top reviewers. Thank him."
And Jed, since you mentioned that, what's the metric for that? Is it number of reviews, speed of review? What makes someone a top reviewer?
I'll let Bill comment.
Well, actually, we can pull all that data from Editorial Manager, the Elsevier editing website, and it gives a speed of review, how often you accept a review, how often you reject, how often you accept papers and things like that. So I just have a couple little comments because Jed really covered that comprehensively. But for the reviewers, and Michael kind of said this, one thing doing reviews, it helps you learn how to do your research. It improves your research because you see what other people are doing wrong when you do the reviews. And it helps teach you how to write a paper. I can tell you, I don't really write too much anymore because I did so much editing for 17 years, but I think I could get any paper I wanted to write accepted every time because I know exactly how to write it based on what I've done over the last few years. And that's what reviewers learn. They learn how to write the paper. And people say, well, how you write it doesn't matter. Believe me, how you write it matters a lot. If you write something that's just garbage, it overshadows the science involved in it. And one other thing that Jed talked about confirmation bias, that hopefully the reviewers will do this, because I always tried to do this, especially I was the final goalkeeper. In the conclusions, you see people using spin all the time, using their confirmation bias. Remember that lawyers and insurance companies see these papers eventually, and they use them against us. So, be very careful on what the conclusion's saying, that it's actually based on evidence they found in the study, and that they're not exaggerating it so they can, show people how good they are. And that's really important. And it was my job always to make sure that people didn't say things that were so inflammatory they were going to show up in a court of law someday for a malpractice suit. But that comes from confirmation bias and spin. And Jed, I think we need to go, so I'll let you finish here.
Yeah, well, I just want to thank everybody for attending. We're kind of running out of time now. This will be available. It was recorded, so Steve tells me it will be available on the ASES YouTube channel, and I think it'll be somewhere in the website. Is that right, Steve?
It'll be available on the mobile app and the YouTube channel tomorrow, and then on the website at some point in the coming weeks.
Awesome. Well, thanks for attending, and thanks for working for the journal for us. You're making it a success, and we appreciate each and every one of you who reviews.
Thank you.
Thanks, everyone.
Thanks, everybody. Good night.